We are live.
Okay. So, good evening, postgraduate, and welcome to this 90th episode of All India Ophthalmological Society ARC PG teaching program. So, as you are aware, we have started a series on research methodology, understanding how to do it. And today is the third episode on that particular subject. Let me thank all the respectable faculties who have joined here for this particular webinar, sparing their valuable time. And now, without much ado, can I request Dr. Kasturi Bhattacharya, ma'am, who is the moderator for this today's session, to carry forward the further proceedings. Ma'am, please.
Thank you, Dr. Prashant. And I should thank you all in the Ophthalmological Society and ARC for having this webinar. This webinar has become very popular as we were discussing. Like every morning, I'm getting messages. People are asking that we want to learn more and we should have more of such webinars. Very much thankful to our esteemed speakers today, Dr. Namrata Sharma and Dr. Sushmita. Dr. Namrata Sharma, who is a most reputed ophthalmologist, who is doing so good not only in academics but in leadership position, and she's really an inspiration for older women. Very recently, she was in ASCRS. I'm sure that she had just come back and she has won a best paper for a study done on 60,000 patients. So thank you very much, Dr. Namrata, for joining us. And Dr. Sushmita, she is one of the best, researcher in glaucoma that I have seen her over the ages. I have been following her, the way she presents a paper, the methodology, the research, it is really amazing. We look forward to listening to her. And I'm very much grateful to have Dr. Parul. Dr. Parul is professor from Government Medical College, Chandigarh, and she has been moderating all the sessions. Her first topic on research methodology was very inspiring and very insightful. Thank you, Dr. Parul, for being with us for all this session. Dr. Shubham, a young researcher who has been helping us in every aspect, very dynamic, very talented, and very intelligent. And we have Dr. Usha. She is a great leader and an inspiration for all of us. Usha is a friend, philosopher, and guide to all of us. She's always there with us for any of the sessions or for any scientific meeting. And two young panelists, we have Dr. Anujit and Dr. Aishi. Thank you so much for joining us. And now I request Dr. Shubham to introduce the faculties in details. First, Dr. Namrata will be speaking. First, Dr. Namrata, Dr. Shubham.
Okay. Thank you so very much, ma'am. It's a pleasure and an honor to introduce the speakers for tonight. First, we have Professor Namrata Sharma. She's the Cornea, Cataract and Refractive Surgery Services from the Rajendra Prasad Center for Ophthalmic Sciences at the prestigious All India Institute of Medical Sciences in New Delhi. She has a fellowship from the Moorfields Eye Hospital in London, United Kingdom. She's been the chairperson, scientific committee of the All India Ophthalmic Society, the president of the Cornea Society of India, and to her name are two patents. The first Indian to be inducted as a Director at Large, international member in the Cornea Society International of United States of America. She's an elected as a member of the Afro-Asian Council of Ophthalmology. She's inducted as the council member of the Asia Cornea Society from India in the year 24. Inducted as the section editor, Cornea and External Disease from the British Journal of Ophthalmology in the year 24. Two international awards to her credit include the first Dr. Paul Dubord Award for International Eye Banking by the Global Alliance of Eye Banking Associations at the Asia Cornea Society meeting, Jakarta in 24. She featured in the 2023 Stanford list of the top 10 highly cited ophthalmologic researchers and in the top 2% scientists in the world conducted by the Stanford University. She's among the list of 100 top powerful women ophthalmologists in the world. She's the top 100 most influential ophthalmologists as per 2022 guidelines by the Asia Pacific Journal of Ophthalmology for the outstanding achievement and significant contributions to the field of ophthalmology in the Asia Pacific region and beyond, dated 23. She also has to her credit is the Senior Achievement Award at the American Academy, an International Ophthalmic Education Award at the American Academy again, and to her credit are the Best Video Awards by the ESCRS, RANZCO, and the Best of Show Award 6 times by the American Academy. She is an extensive publisher and has over 650 publications in international peer-reviewed journals, which speaks high volumes of the graded research she follows. She has authored 19 books and the instruction courses at several international and national platforms, and a name which is synonymous with Indian ophthalmology. principal investigator in many multicentric international FDA and RCTs, which have changed the clinical practice and how we practice cornea and external diseases per se in the world. Over to you, ma'am, for tonight's talk.
Thank you so much, Shubhav. And I would like to thank Dr. Kasturi, one, for organizing this. I think these are research is something which people don't really pay too much attention to, and also for having me on this platform. I would be talking to you about something which is very close to my heart, and more so because although we publish, but I think the pinnacle of publishing is the fact that it should be related to clinical trials and it should be evidence-based medicine. And although when you are in the beginning career of your publication, you don't mind publishing case reports or letter to editors or small case series, but the real evidence actually comes from the randomized control trials and clinical trials which are done after following a particular methodology. So for all the postgraduates, I would like to say that your beginning is your thesis, and I think thesis is something which you should all pay attention to. And then as you do your post-graduation, go into senior residency and maybe go into academics, or even for that matter, private practice, it is important and good to publish. All private practitioners who have actually become successful then go on to publishing their research. So what is evidence-based medicine? It is an important thing that the central role of evidence-based medicine in modern ophthalmic practice does exist, and there are 5 steps to this. You ask, that means you formulate a focused clinical question relevant to ophthalmic practice. Acquire, that means efficiently search for the highest quality evidence. Appraise, that means rigorously evaluate the validity and applicability of the evidence that exists. Apply, that means integrate evidence with clinical expertise and patient-specific factors. And then you assess, that means you monitor outcomes and refine clinical strategies. So the ultimate outcome of a evidence-based medicine is that you come to a clinical practice which is reproducible, which is simple, and which actually has clinical implications. Now, there are various levels of evidence-based medicine. So we look at the highest level, it is the randomized control trials. Then you have level and the systematic review of all the randomized control trials will give you level 1. Then level 2A is randomized control trial. Level 3A is pseudo-randomized control trial, which is alternative allocation or some other method, but not actually randomized. Level 3B is when you have cohort studies, case control studies, and you can have an interrupted time series with a control group in these cases. Level 3C is when you have historical controls, 2 or more clinical arm studies, and interrupted time series without a parallel control group. Level 4 is a case series, and level 5 is just your expert opinion or critical appraisal, which is based on the bench research or based historically on the clinical principles. So this is as far as the level goes, and you can see very well that it is the randomized control trials, which is one of the top levels. Now, clinical trials are important because they ensure progress in ophthalmology. And the purpose, like I said earlier, of a clinical trial is to evaluate novel treatments, which could be for corneal disease, glaucoma, diabetic retinopathy, etc., and also to compare surgical techniques and novel techniques and technologies with the standard that is available. And the ethical imperatives in ophthalmic clinical trials is that one should have informed consents, there should be beneficence, that means it should be beneficial, then equipoise, there should be justice, and the data integrity is of uttermost value as far as the clinical trials are concerned. And then there are phases of clinical trials as discoveries are made. So you have studies in the lab, then studies in animal models. Phase 0 is when the first study in the patient to see how the body metabolizes the drug. Phase 1 is when the study of small number of patients to evaluate the safety and dosing of the drug. Phase 2 is the study of more patients to assess drug is effective and further to evaluate the safety. Phase 3 is the study with the largest number of patients to confirm drug is effective and safe and assess the side effects and compare this drug to the current treatment available. And phase 4 is when you do the surveillance of the drug which is done by a regulatory, which could be like CDSCO or FDA approved drugs to evaluate long-term safety or long-term effects in a diverse patient population. So the phases of the clinical trial, like I said earlier, are the preclinical foundations, and you have initially the lab models or the animal models which lay the groundwork. And the purpose is to assess the safety and preliminary efficacy in these animal models. Example include in vitro studies of drug toxicity in retinal cells and animal models of neovascularization. Phase 0, sometimes this may be applicable and sometimes this may not be applicable. It will be applicable if it is related to the drugs. It is basically the microdosing studies in ophthalmology. That means you use a targeted approach, and phase 0 trials are relatively few. They are not always required. And they might be used to assess how well a drug penetrates into the different parts of the eye. It is important to note that phase 0 trials don't provide any information on whether the drug actually works or not, but just tells you about the pharmacokinetics. Then phase 1, safety first. Phase 1 are the small group studies because you want to establish the tolerability of the safety. So you establish the dose of the drug, the maximum dose which is tolerated. And the focus is on the pharmacokinetics, that means the ocular drug distribution, and the pharmacodynamics, which means the effects on the intraocular pressure, retinal function, etc. Phase 2 trials involve a larger population who have that particular condition, and the treatment is designed to treat it. The goal is whether the treatment is effective and to actually work out the particular or refine the dosage regime. And for example, phase 2 trial might evaluate the effect of a new drug on visual acuity in patients with macular edema, but researchers will continue to monitor the safety of that particular treatment. So basically, it relates to the proof of the concept and to the safety of the drug. Phase 3 is the pivotal trials, which are large-scale randomized control, which confirm efficacy and safety. And these are designed to confirm and monitor the side effects, compare the treatment to the current standard of care, which may be the gold standard at that particular period of time. And phase 3 trials are often multicentric trials, which means that they are conducted in more than one site. And different surgical, for instance, if you have, say, a multi-center trial which compares different surgical approaches for cataract extraction, that means this is a phase 3 trial, and this will help us to determine whether each of the surgical technique is associated with some complication, less or more. Then phase 4 trials are long-term surveillance. That means they are post-marketing studies and real-world effectiveness. And examples of the purpose is gathering additional information on the long-term side effects and even the rare adverse events. And it is important to monitor the incidence, for instance, of endophthalmitis following cataract surgery. So just to give example, the first in-human anti-VEGF trial had a sample of 20 to 100 for safety and dosage. But when you do phase 2 trials for efficacy and side effects, your sample size would increase 100 to 300. When you do multi-center trial, it will further increase, which will be phase 3 to confirm the efficacy. And when you further increase when you do the long-term safety, then the sample size again has to increase to thousands. And in real world monitoring or for post FDA approval, or in India for post CDSCO approval, you would require this. Now, what is a randomized control trial? When you do a rigorous evaluation, and it is gold standard for evaluating the effectiveness of an intervention. The key features of randomized control trials are that you have to do randomization, minimizing the bias. You have to have a control group, and then you have to have blinding or masking to ensure the objectivity. And RCTs are gold standard in ophthalmology. For example, there are lots of RCTs which have been done, like the diabetic retinopathy study, the ETDRS, and the CAT. The anatomy of the randomized control trial is this, and this is important because every journal would ask you about this. So you have to first assess the eligibility, you have to randomize it, allocate to intervention, received, whether how many have received intervention, how many have not, how many have discontinued the intervention, that is important, how many were lost to follow-up, how many were followed up, and how many were analyzed. So in this whole process, even if there are some patients who are lost to follow-up, or in some patients where the result was not analyzed because they were lost to follow-up, those also you have to enter. That means the entire cohort gets entered into this randomized control trial chart. Now, what is critical appraisal of the RCT? A process of carefully and systematically examining the research to judge its trustworthiness is what is critical appraisal. And this is essential in ophthalmology because it navigates a sea of information. The key questions to ask are whether you have a structured approach or you don't have a structured approach. Now, the critical appraising of the RCTs also have to undergo the internal validity, which means minimize the bias. So the bias can be of several types, like the selection bias. That means, was the randomization truly done? Performance bias, was blinding maintained? Detection bias, were outcome assessments objective? Attrition bias, that means, was the follow-up complete and balanced? And reporting bias, were all outcomes reported or not? So under each of the factors, the validity of the RCT has to be tested. Then you have to see whether you can apply the results to your practice or not. That means, are the study participants similar to your patients or not? Was the intervention feasible in your setting or not, as vis-a-vis the equipment and expertise? And if the outcomes are relevant to your patients or not in terms of visual acuity or quality of life. Now, again, when you do appraisal of the RCTs, it is important to study the statistics, because statistics may tell you something, but the clinical significance of that may be otherwise. So your interpretations have to be vis-a-vis the clinical implications. And the real world benefit, for instance, of absolute risk reduction would be different, of relative risk reduction would be different, and number needed to treat, of course, is a practical measure. Then you have to apply the evidence to the clinical practice, which means it is done by a collaborative approach, which means the clinical expertise, what the clinician knows, the best research evidence, what the literature says, the patient values, what the patient wants, and all this then forms into a win sort of a thing. When you collate the information, becomes the evidence-based medicine. So it is not that you just follow the guidelines blindly, because it is about integrating the best available evidence with your clinical expertise and your patient's values and preferences. And they are essential for making informed decisions which are aligned with the patient goals. So just applying evidence to clinical practice guidelines and protocols, this is a framework which is done for consistency. Like the American Academy of Ophthalmology comes with the preferred practice guidelines. Then All India Ophthalmological Society comes with the preferred practice guidelines. Cochrane Library or PubMed, etc., will come with the preferred practice guidelines.
Hello.
Yes, yes. So in order to conclude, the clinical trials and evidence-based medicine are essential for advancing the field of ophthalmology and improving the patient care. And this is a lifelong learning, and this helps to make the informed decisions. Now, just to give you some examples, this was a study done by Professor Tanuj Dada from our center. This is in the order of appearance in the PubMed, and so this is one of the latest study where aqueous angiography was done to compare two procedures. So once you have to compare two procedures, then you do need a randomized control trial, especially when you have one standard of care and one new procedure which has come. Now, this was a study where we did try to look at the biomechanics in PRK versus SMILE for similar amount of myopia. And again, this was a randomized control study. I think till date, we've published 41 randomized control studies from at least from our group. Again, this was a very important randomized control trial to show whether SLET works better than CLET or not. Cultivated limbal epithelial transplantation is done in the lab. It requires a lot of money, whereas simple limbal epithelial transplantation is like growing the stem cells onto the eye itself without requiring the lab. And we did show that the results are comparable, and SLET had better visual outcomes. So from the patient perspective view and from the surgeon point of view, it changes the entire thing completely. So you don't have to spend more now, and you get the same outcome or better outcomes. Now, this was a multi-centric trial which involved 3 centers, and this was, of course, investigator-initiated trial where lifitegrast was looked at whether it is helping in patients with dry eye or not. And again, this was randomized double-blind active control trial. So this is to say that when you do multicentric randomized control trial, the weightage of the study increases. Again, similarly, this was again comparing two formulations of cyclosporin, one which was micellar nanoparticulate and the other which was not. And again, to see whether one is better than the other. Now, this was by Professor Rohit Saxena, atropine for treatment in childhood myopia in India, multicentric randomized control trial. Again, this looked at two concentrations to see which one is better. Subsequently, low dose heparin and ocular SJS. Ocular SJS is a very difficult condition, and we wanted to see whether topical low dose heparin works or not. So we again took two cohorts in which in one set of patients, we put low dose heparin and we found that the results were much better as compared to the other. So for these cases which actually have no treatment at all, even if you prove that something like a topical low dose heparin works, it is a big relief for them because from category in which they are blind, they become at least they get navigatory vision. I think this is one of the landmark papers again, which looked at whether topical cyclosporin 1% helps in cases of SJS or not. And I think this is this study we did at RP Center in collaboration with AIIMS. Again, a very useful study because you don't get acute SJS so much. And when you do a randomized control trial, you come to know that amniotic membrane does help, so much so that there are no sequelae of chronic SJS in these cases. So from the patient point of view, it makes a lot of difference. So this is just to say that there are several of these kind of randomized control trials that we have done, which have established the efficacy of one particular treatment as compared to the other. Again, notably here we did show in this again randomized control study that cord serum is much better than autologous serum for epithelial defect healing. So it establishes the efficacy of one procedure over the other. Again, I think we did randomized control trials because at that point in time, or now for that matter, now of course our records have become really robust. But at that particular point in time, our retrospective records were not that robust. And so the only way of doing studies onward was to do randomized control studies. And once you do the RCTs, they get published in good journals like ophthalmology, like British Journal of Ophthalmology. And that also adds to the fact that a lot of people read it more, and also you have more citations. So these are some of those RCTs only which have actually changed the way we do our, at least treat our cornea patients and ocular surface patients, cataract and refractive patients, which have made a difference. And these have all been done by our group. The trend of RCT was started by Professor Rasik Vajpayee, and I would like to acknowledge him. He is my teacher and he actually got us into this, and we have been continuing to do this for now ever since I can remember, which was, I think, as long as since 1999. So thank you so much for your kind attention. And I just would want to again highlight the fact that evidence-based medicine is the way to go. You may show a case, you may show a video, but unless you have proof of concept that one treatment works as compared to the other or not, you actually do not reach anywhere. So thank you very much for your kind attention.
Thank you so much. Yeah, Dr. Farooq.
Ma'am, it was really inspiring, and 650 publications and so many RCTs are just very, very inspiring for everyone. Ma'am, I have a question. The traditional hierarchy of levels of evidence does not include the real world scenarios, the studies which are coming out with the real world scenarios. Ma'am, where would you place such studies? Especially after anti-VEGFs, there are multiple studies as what is the outcome in the real world.
No, I do understand that the real world studies also, are there. And when you say patient reported symptoms or what actually the patient reports, I think they also make a difference. Only thing is they have an element of subjectivity in it. And so you tend to get a little bias. Plus, I think there is another element to it. Most of the real world studies are driven by the companies, whether it is related to intraocular lenses or to anti-VEGFs. So I think that again has to be taken into consideration, because once that happens, then there maybe, I'm not saying there is, maybe some element of bias in that. But yes, real world studies are again something which cannot be ignored and should not be ignored, because whatever your statistics and whatever your values say, if it is not troubling the patient, then I mean, it doesn't matter.
Right, ma'am. Thank you, ma'am.
Okay.
Ma'am, I have a question.
Yeah.
Just to discuss the safety profile for the principal investigator. You've been a principal investigator for many of these trials. So for those who are just starting out, what would be the implications if you had an adverse reaction to a drug in these patients, a practical scenario, and how the principal investigator is protected? And for those who would venture for the first time into clinical trials, what should they keep in mind when they are accepting a clinical trial, so to speak?
So I think first and foremost is that you should get a ethics approval from your own institutional committee, whatever your IRB is, because that actually does help you to, as far as the safety is concerned, you have that on paper. Second is you have to, if you're involving a clinical research coordinator or a clinical research team who's actually making you do a trial, then the credentials of that particular team are important. Not that they matter a lot, because almost all of them would follow the same protocols, but still it makes a difference. Third is that you should get them registered. This is mandatory now, even for publications, that you have to get them registered, especially if you're doing trials on the clinical trial registry. And there are several registries available, CTRI from India and others from other countries. And I think the fourth thing is that even if you do have an adverse event, it is important to document it. And if you don't document it, then you're in a greater trouble and the patient has it. And if there is a litigation, then it creates a problem. But everything which is documented, even if it is an adverse event, will not create a problem for you. And of course, informed consent, you have to take following all the guidelines that are there. In between, you have to do video recording also for the randomized control trials. So it is best to take the informed consent from all the patients. And then, like I said, if you have an adverse event, there's nothing wrong with it. Only thing is the proper documentation should be there, and proper follow-up of the protocol will be there, that in case you do have an adverse event, do you switch to another group, or the patient leaves out of the thing completely, or whatever your protocol says. So if you follow that, I don't think you will fall a prey to any of the I mean, you can go ahead and do it without any problem.
And do we have a different set of regulatory or ethical rules in case of clinical trials for the vulnerable groups?
So I think they do have, and they have several set of categories. They have some of them, sometimes even if the drugs are not approved, we use them because they are orphan drugs or just as mercy cases. So appropriate regulatory approvals have to be taken from appropriate agencies, and these agencies are well defined. If it is devices, you have to go to CDSCO. If it is drugs, then you have to go to DCGI. So if you're safe from those angles, I don't think there should be a problem.
Just
But
one sorry, go ahead.
Yeah, it is best to take professional help, because once you start these trials, you're not into it really. But as you go by and by, then you realize, because there is a different set of problems with every trial and every study.
So just one small comment also, it's important for, especially I would reach out to the students, that don't go by the two-liners that your drug companies would come and give you, or the flashy points that you would say. I mean, a case in point is the TVT study, the trap versus tube study. And it was rubbish that the trap has so many complications and blah, 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 and the tube is so much better, and they use the AGV. But if you really went in, and they didn't say it in the abstract either, and then if you actually read the paper, they use 0.04% for 4 minutes mitomycin. Who uses, concentrations like that? And ultimately, they faced a lot of flack, and they came out with the primary TVT study in which they actually brought it down to 2 minutes again. So there's a lot to, like Parul said, your actual real world when you would not be doing things, and you read the fine print, and it was actually investigator driven by AGV. So like Dr. Namrata said, you must always read the fine print of where affiliations are and take the scientific content out of it rather than just blanketly, accept.
So thank you, Dr. Namrata, very much. And Dr. Shubha, are you there? Can we go to the next topic, please?
Yes, ma'am. It's a pleasure again to be reconnected and to introduce the other speaker for tonight, Professor Sushmita Kaushik. She is from the Advanced Eye Center, PGI, Chandigarh. Her keen areas of interest include the newer imaging modalities, childhood glaucoma, MIGS, and glaucoma surgery. The special achievements to her credit include 175 publications in indexed international and national journals, 51 chapters in various textbooks. She has authored the educational module on primary congenital glaucoma for the World Glaucoma Association, dated 22. The leadership position she has held is the founder secretary for the Indian Pediatric Glaucoma Society, former secretary of the Glaucoma Society of India, and the senior vice president of the Chandigarh Ophthalmological Society. Special honors to her name include she was the invited member from the India of the Worldwide Childhood Glaucoma Research Network. She's the visiting professor at the Bascom Palmer Eye Institute, University of Miami in the United States. She's the member of the CDSCO, Ministry of Health and Family Welfare, Government of India, and a member of the task force for the India-US Joint Proposals, the DBT, Government of India. The notable awards include the B.K. Narayana Award, AIS 2025, the Noel Rice Lecture, awarded oration by the United Kingdom Pediatric Glaucoma Society in Jan 2023, the Prabhakaran Memorial Oration by KSOS, July 23, a keynote lecture on advanced pediatric cornea workshop at the LV Prasad Eye Institute in Hyderabad in 23, Rustam Ranji Award Lecture, oration awarded by the LV Prasad Eye Institute in 22, a keynote lecture at the Royal Manchester Eye Hospital in UK in 2022, Honor Award for significant contribution to glaucoma, Glaucoma Society of India in 2022, the Ophthalmic Hero Award by the AIOS in 23, 17, 2025. Over to you, ma'am, for tonight's talk.
It is on, it's okay. I don't know where it's gone, sorry. Should I sing it up? Okay, I'll come in again. Is it visible?
Not yet, ma'am. Could you minimize this window and then go on to the PowerPoint?
This, but when I said this is, which window, this one? No. Where is this gone?
Actually, I think your PowerPoint is open. You have checked, just close the PowerPoint, go to a system,
Should be,
the PowerPoint,
it
totally.
should work.
It's
Yes.
visible.
Yes.
It's
Yeah.
now visible.
Yeah.
You may make it full screen now.
Yeah, let me make it full screen.
Perfect.
Right. So at the outset, thank you very much, Dr. Kasturi and Dr. Prashant, for this invitation. And I quite enjoyed Dr. Namrata's talk, and it's a nice follow-up of the RCTs that she's talked about. So when Dr. Kasturi gave me this topic of literature search and systematic review techniques, I was wondering that this is a 1-minute thing, open PubMed, put in your keywords, and there you are. But anyway, thank you for giving me this, because it made me read and it made me go through a lot. And I came across with very interesting things, and I hope to put it all in perspective. So what is a literature review? It's an analysis of existing research on any specific topic. And it presents an overview of current knowledge, the gaps in the current knowledge, and the research trends and what could be possible. So why is that required? Because you need to identify how your own research project can build upon and extend the existing knowledge in your area or your field of study. So your outline for today would basically be to conduct a structured literature review, and that's like going to the market and seeing so many melons and wondering which to pick out. And then critically appraise the existing research, in which you pick out the best ones and you take them home, and those are the ones which you think are most useful. So these are the types. You have all kinds of melons in the market. So you have a narrative review, which is the broadest. It's an overview. It's often subjective. It's just a review of any topic which you pick up. Systematic review, on the other hand, is focused, it's replicable, and it's rigorous. So it really looks at one small focus, and we'll hear more about it in the next couple of slides. The third major type of review is a scoping review, where it maps the key concepts of any subject that you want, and especially when the evidence is just emerging. And in the context of glaucoma, I guess it would be MIGS, because that would be a scoping review, because there's not much to do a full literature review on. And a meta-analysis is a quantitative synthesis of study results. So people have been doing the same thing, say for 10 years, and you analyze all of them together and then try to see whether you can get a nichode, or you get something out of that, all the literature that's been written. So we'll go across them one by one. The narrative review is what I guess a PG student does. Just picks up that one keyword from PubMed and lists all the articles that they can get. It can be quantitative, it may be qualitative, and it may span many, many years. So the steps for a narrative review is, of course, to search for relevant literature. You use appropriate search terms to identify key articles. Then you evaluate and select your sources. So you filter the source list by selecting directly relevant studies. So you look at good quality, you look at objectivity, you look at accuracy, and you look at how valid it is to your study question. Then you analyze and synthesize what you found. You review each score, and you have to read that and summarize the main arguments. Maybe you can keep these summaries in a table. So if you're looking at one aspect, say, of possibly what is the effect of latanoprost on the cornea, so then you see corneal clarity, then you see endothelial cell count, you see corneal thickness, and you put them down in a table, and you put in as many references as you can get on each particular thing. And then it's nice to identify a theme. Otherwise, ophthalmology is such a vast thing. You group studies that share common themes, such like studies that have similar findings or methodologies. And then finally, you sit down and write the review. So write the review based on the themes or subtopics that you've chosen. You need a thorough overview of each theme. You integrate the source data and conclude with a summary of the current state of knowledge. So you summarize what is known, and then you also, at the end, suggest ideas for future research based upon an evaluation of what you think is lacking in literature. So it gives you that area of what next. And then comes the systematic review. And this is what the Cochrane Handbook for Systematic Review says. Basically, it's a clearly stated set of objectives. And the main difference is you have predefined eligibility criteria. You have an explicit, reproducible methodology. Without a good methodology, you can't add something into a systematic review. And then you do a search to identify all studies that meet your eligibility criteria. So it's a little more robust than just a narrative review, because you have sort of made a protocol before starting the systematic review that this is what I'm going to look for. And then you assess the validity of the findings of the studies that fit your inclusion criteria, for example, through the assessment of the risk of bias. And then you present all of this as a synthesis of the characteristics and findings of the studies that you included. So an example of two of them to start with, say you have a topic of ultrasound biomicroscope. So you do a narrative review of UBM for all conditions in all situations, and that would be, say, a small, maybe even a small textbook of ultrasound biomicroscopy in ophthalmology. That would be a narrative review. But a systematic review would be focused. You would say, I'm going to see what is done in UBM in children, or UBM in glaucoma, or UBM in strabismus. Similarly, MIGS. You can do an overview of MIGS, which will be nice to write in, say, any review journal. But a systematic review would be, how does MIGS work for juvenile open angle glaucoma or primary angle closure, or even in children? So these are the examples of differences in a narrative and a systematic review. So the steps for a systematic review would be define the research question. That's the most important thing for any study. PICO is the acronym given. Which patient are you looking at? What are the interventions that you see? What comparisons are you going to look at? And what outcomes are you looking for? And then you develop a protocol, and you must have heard of this. Once you develop the protocol, it's registered. Once you register things, then you're sort of duty bound to do that. So the Prospero registry is for registering your systematic review. And this is an international systematic review registry. Once it's registered, then you conduct a comprehensive literature search. You use PubMed, Scopus, Web of Science, any source and all sources that you think are relevant. And then you mesh your terms. Now, what meshing means, you must have seen that. It's actually a full form for medical subject headings. So you mesh your terms, say MIGS and children, and would be in capitals, or trabeculectomy and primary angle closure glaucoma. So you mesh your terms together, you combine the headings, and then do your literature search. Now, once you've done that, you get, of course, say 150 studies, and then you screen them and you select them, and then you extract data. Now, remember, you've already made a protocol. So you have defined study characteristics, you have participants, you have interventions, and you have outcomes. So going through these studies that you come across is easier because you already have a preset defined criteria of what you're looking for. And it's always a good idea to extract data by two reviewers independently to remove whatever little bias there may be. And then you need to critically appraise studies. And how you do that is you actually assess for risk of bias. And there are lots of tools, and we'll just briefly go through them. So these are the tools that are available. These are various checklists that you can do to remove bias, or at least assess whether the studies that you have include bias as well. So let's talk a bit about critical appraisal. Now, critical appraisal is asking yourself, is this study good enough? That's the moot question. So the main thing is assessing the risk of bias and checking for methodological quality. Now, the key questions that you need to ask when you critically appraise any article is, what is the research question? Was it there? Is the study design appropriate? Are the methods valid and reliable? And are the results significant and applicable in your daily clinical practice? So those are the key questions that an appraisal would come in. Now, what are the things that you're going to evaluate in this appraisal? You'll evaluate methodology. What are you going to look for? Sampling. What is the population? What was the intervention and what was compared? Are there outcome measures? Was anything blinded? Was it randomized? Is there robust statistical analysis for the data that has come in? And how generalizable these findings are? Can you put them into your daily clinics? Then, of course, you assess results for significance. So the most common is p-values and confidence intervals. You look at the effect size and you look at the risk of bias. And then you sit down and interpret the conclusions. Are these conclusions supported by data? So the article might say anything, they might conclude anything, but many times even as residents, you might have sent out your thesis and you might get back a reviewer comment saying that remove this conclusion because it's not supported by data. So you're seeing some data and you assume a conclusion, but your data doesn't give that conclusion. So you have to remove that. Any overgeneralization or unsupported claims. So you need to look out for wide variations. MIGS is generally a better surgery than a TRAB. Now, these overgeneralizations are not. So the questions you will ask is, in which patients? For how much pressure? For what stage of glaucoma? So that's how a systematic review is really, really protocol driven. And then you consider alternative explanations for the results that this article has come to. So just quickly going over some tools which are available. One is a critical appraisal skills program, a CASP checklist. What this means is it gives you a set of questions, so you don't have to break your head about it. So you have lots of checklists available. You just download them. There are sets of questions to evaluate different study types. For instance, for the CASP checklist, you have section A, B, and C, and they cover, are the results of the review valid? What are the results? And will the results help us locally? Then you have a Cochrane risk of bias tool, again available online, free, to assess bias in randomized trials, which are included in Cochrane reviews. So it gives you a bias assessment tool by itself. This is very commonly used, the AMSTER. The full form is a measurement tool to assess systematic reviews. So it's self-explanatory. It's an instrument designed to evaluate the methodological quality of systematic reviews and assess the study selection, the data extraction, and synthesis of findings. So all that we've talked of critical appraisal comes in the AMSTER 2. And this is an example of page 1 of AMSTER 2. And they just have these questions which you just need to say yes and no to. And once it gives you a score of whether this article is robust enough to be included. Now, in practice, you need to integrate this appraisal with clinical expertise and patient values. You need to use this appraised evidence in decision making. Now, that's the most important thing. You've read the article, you're impressed by it, but would you be able to alter your decision in your clinical patient management, and encourage a culture of questioning and inquiry? So keep questioning, is this valid? Is it okay for me? Now, the main appraisal skills are, if you take them, then it enables you to assess systematically the trustworthiness, relevance, and results of published papers. And where an article is published or who wrote it, that's important. Who wrote it should not be an indication of its trustworthiness and relevance. So that's an interesting point that they make. Now, once you have all this and you think this article is good enough, you need to synthesize your findings, which means you need to synthesize the narrative for a qualitative data, and you need to do a meta-analysis for comparable data. So if it's values, you need to do a meta-analysis of all the studies that have been done, and then also consider population and ethnicity bias. For instance, maybe one part of the world may not have Epstein-Barr virus at all. So having an RCT or having an antiviral drug which works very well against it may not be applicable to a part of the world which does not see the disease. So consider all that as well. When you're reporting, you need to follow, I'm sure you've heard of this many times, PRISMA guidelines. Now, PRISMA is a full form for preferred reporting items for systematic reviews and meta-analysis. So these are the PRISMA guidelines. Again, it's a checklist. So you can use CASP, you can use PRISMA. This is a checklist. You just have to keep noting them and saying yes or no. And it's very useful while trying to evaluate whether a systematic review or something has looked at these things. Always include a PRISMA flow diagram. Now, this is what a PRISMA flow diagram is. If you're ever doing an analysis, the four main things are identification of which are the patients, screening, how are you going to screen the articles, the eligibility once you've screened them, and the inclusion. So once you have this flow diagram, if you write a systematic review, these are what need to be uploaded along with them. You need to have a PRISMA checklist, and you need to have a PRISMA flow diagram to show how you went about your literature search. Now, you need to report what your search process was, which means what tools did you use? Did you use PubMed? Did you use Web of Science? Did you use Scopus? What was your selection process, which comes here in your PRISMA flow diagram? What were your predefined characteristics of the studies? Did you only include RCTs? Did you also have case series? And how did you do a result and quality assessment? So the common pitfalls to avoid while doing any of this is an inadequate search strategy. Let's not be lazy. Do a complete search strategy. Sometimes you might have poorly defined inclusion criteria. That's the bugbear of most research. Lack of duplicate screening or appraisal. There could be duplicate articles even in literature. And if you're not assessing quality or bias. Selective reporting is another problem because those are where our bias is coming. I believe something is better, so I will only report those things are better and hope my review validates what I think, but that's not nice. Quickly, I'll go through what a scoping review is. So the narrative and systematic are the most commonly used, but you have something called a scoping review, which means a systematic approach to identify and synthesize an existing or emerging body of literature on a given topic. So it's still coming, it's still happening. It's not part of practice, clinical practice yet, but then you can map the extent, the range, and the nature of the literature and determine possible gaps in the literature on a topic. So where is it missing? What is it not answering? But it's not limited to peer-reviewed literature. So you can have anecdotal, non-peer-reviewed articles and also talk about them. So the difference between a scoping and a systematic review would be the focus is broad, as you can imagine, but a systematic review is very narrow. Quality appraisal is not always added because it's not always peer reviewed. This is always included. The purpose is just to map evidence of something which is new and identify some gaps, something which is not known, whereas a systematic review answers a very specific research question only to peer-reviewed literature. And the outcome of a scoping review is an overview, what is the theme of the subject, and what are the gaps to be filled. But a systematic review looks at evidence-based conclusions. A systematic review tells you, this is what evidence says you should do. This is evidence-based medicine. And the last bit is a meta-analysis. Now, this is compiling and analyzing data from multiple independent studies to produce a single summary statement. So, acha itne sare, there's so many that have talked about a certain this versus that. Tell me what I should do. So when there are multiple studies on the same topic or questions, multiple groups doing the same thing, the studies are sufficiently similar in design, population, and outcomes, and we are looking for a precise estimate. We are looking at risk ratio, odds ratio, mean difference. So you're looking like, say, healing of a corneal ulcer, or resolution of macular edema, or intraocular pressure control, anything which is a parameter which is defined. And that's what a meta-analysis would tell you. And you have to give forest plots. Now, forest plot is a visual summary of the effect sizes from individual studies with an overall pooled estimate. So I'll just show you what that means. So this, again, my glaucoma bias is there, but I thought this was nice. This is a comparison of a tube shunt implantation and trabeculectomy for glaucoma. And this is a systematic review. So it includes this PRISMA flow chart. So it tells you how these studies were taken. How did you identify them? What did you screen for? How were they? What was the eligibility? And what are the parameters that you included? So this is how a forest plot looks like. So you see, this is tube versus trab, but it's split into two. The tube is Ahmed, and this is a Barwelt. These are the names of the studies. And these are the mean IOP at the end, because their output was the intraocular pressure. And this is the box forest plot, which gives you an odds ratio. And some of these studies, you can see the Barwelt, it favors a trab, whereas the Ahmeds, some favor the Ahmed and some favor the trab, and they're not really conclusive. But a Barwelt always seems to favor a trab more. There are just two studies which sort of favor the Barwelt, but by and large, they said the trab is better. So this is what a box forest plot tells you. It gives you an idea of the odds ratio on which side is it sort of leaning on the basis of all these studies. So this is a typical output of a systematic review. So to summarize, a structured literature review is the key to evidence-based practice. Yes, when systematic methods ensure transparency and reproducibility, but critical appraisal ensures the trust in these findings, and we need to use available tools and frameworks for the rigor of the study. Thank you so much again for the invite.
Thank you for the insightful talk, ma'am. If I can ask a couple of questions. So do you know of any resources where we can learn how to do meta-analysis? Because I've been really looking to learn the same, but haven't found anything yet. Like I have done a systematic review or a narrative review, but when it comes to meta-analysis, I look for resources. So for the benefit of all, can you
I
put some light?
confess I don't have a specific resource, but while making this talk, if you just really search, there are lots of articles which actually take a go through to it. And I think the best person would ask would be ChatGPT. Tell me resources for doing a meta-analysis. It'll give you 1, 2, 3, 4, but offhand, I really don't know. But it's there. I mean, you know, if you really go in, you have the checklist, you have PRISMA guidelines, you have the box flow charts available, you have calculate box flow charts. I tried that as well. So you just input the thing that you want, put in the references that you have, and they'll give you a box flow. I mean, the internet is just at your fingertips, but yes, we need to work. We need to spend time on it and do it. But I'm sorry, I can't pinpoint a resource, but I can assure you a lot is available on the net.
Thank you. And is it always necessary to cite an article which is on PubMed, like few of the times we come across a very old article that is not on PubMed and we are writing a review article. So do journals accept articles which are not cited on PubMed?
I guess so. I mean, if it's a narrative review, there wouldn't be a problem. But you obviously need to you need to cite the source. An example with the Transactions of the American Academy, which were thesis, which is not on PubMed now. It used to be in our Index Medicus when we were students, but it's not on PubMed. But the oldest and the gold standard articles are there. So I'm sure if you just cite it, there's no such thing that it has to be PubMed. They also accept Web of Science. So they're not absolutely limited to PubMed index journals only. But I'm sure, yeah.
Thank you.
Ayushi, you can try Covidence. So that is a web platform and which I have read in a lot of meta-analysis that the articles are run through Covidence. So I've never done a systematic analysis myself, but Covidence is one of those resources. Probably you can try that.
Thank you. Thank you so much.
Dr. Usha, would you like to add something?
I think Shushu has covered all. So yeah, I have not done myself any web analysis of all these meta-analysis or anything. So it's a good beginning. I mean,
Hello? Yeah.
Ma'am, where would you place these gray resources like the ones which are on Google Scholar? There are many a times a lot of good clinical insights coming into the ophthalmic magazines like Helio or magazines like that. So
they would, I mean, if you say a scoping review of something, so that is included in a scoping review. But I think when you do a systematic review, they really want an indexed evidence-based journal, because I think it's a problem of bias again, because they're usually individual researchers giving their opinion about something rather than really evidence-based. Similarly, after the American Academy, you'll have a lot of things on the video where people talk about what they believe. So there'll be a lot of I believe. I believe you can reduce hyphema if you do this. So a scoping review is a newer thing. It will encompass everything, but it shouldn't be something which is standard of care, which is what I've understood. If it's something you have to say has to be standard of care and evidence-based medicine, then a systematic review and meta-analysis actually is the gold standard. But a lot of open access journals are on PubMed now. So that's, I think, making it almost a little not indexed as well, because a lot of paid journals are on PubMed. So that's something to keep in mind.
3-4 publication of systematic reviews. So what I have taken from Web of Science, then I have taken Scopus, and I have taken PubMed. And religiously follow the Prisma. And all my review articles, the Prisma flowchart was there. So that is how I have been publishing. I feel at least these three you should have, like the search in these three resources.
Yeah. And there are some which are not in PubMed when they're Web of Science, but when you source it to Web of Science, it's okay.
Ma'am, I just wanted to add one question to this. So when we have changing evidence in literature, for example, you had mentioned MIGS. So what we used to think and the way we used to think about reviewing MIGS has vastly changed in every decade, and it's going to change again. The same things with anti-VEGF. So other than systematic reviews, if a PG is choosing to go for a narrative or a scoping review, there is a high chance that the evidence regarding that article or the topic, or let's say MIGS, the way we consider it will change maybe in 2028 or 2030. So would you encourage PGs to still go for narrative reviews regarding these topics, considering they're easier to publish in this segment, but would not have much of literature weightage maybe 5 years later?
I think it's good to review. I would say as a researcher, it's good to start a review of something which is pretty much in clinical practice, and then review it. So a trabeculectomy and an AGV or a bar weld is very much part of standard of care. So to me, it would make sense if, okay, let me review both of them in various, say, POAG and PACG. To me, that would hold my interest. But if you give me a review of MIGS in POAG, the first thing I would ask is, how long will it last? And we don't have an answer to that because there is no study which gives us more than 2 years of evidence as yet. So in that sense, I think an emerging thing, a systematic review, isn't a good idea because by the time it's going to get published, the data is going to show something else. I mean, in the last 6 months, if you just do a PubMed, MIGS was considered a surgery for open angles. And in the last 6 months, there have been at least 10 papers on MIGS in angle closure glaucoma. So it's as quick as that, people are doing all sorts of things. So that's an example that I'm just sharing.
Absolutely.
Anything more? Dr. Parul, would you like to add something? Dr. Shubha, are you there?
I've done my first narrative review with Sushmita ma'am way back in 2007 when bevacizumab we had started using in glaucoma.
Yeah.
That I think narrative review in the beginning is a very good idea because it gives you the idea of the gaps that are there in literature, and then we can build up more on that, maybe the RCTs or any other study. So I've also learned that no article needs to be read just on the abstract, and that also ma'am has taught us to read in between lines and read the entire article because there is so much that we can miss out, and to read the methodology and the results in a very best of the manners that possible. So yes, I think we need to learn to be thorough from such renowned researchers as Sushmita ma'am and Namrata ma'am. So
Thank you.
Talks by both of you and real good insights and very intriguing. Like it's a research topic, but very interesting. So I think we'll come to, it's almost time. So with this, we come to conclusion. So thank you very much for being with us, especially our chairperson, Dr. Usha Singh, who has been there with us from day one of this webinars or the series of webinars. Dr. Parul for being with us always, and extremely thankful to both Dr. Namrata Sharma and Dr. Sushmita Kaushik for the wonderful talks. It was very insightful, and always I say lots of learning points for all of us. And our two young panelists, Dr. Anuj and also Dr. Ayushi, thanks so much for your inputs also. It was really amazing, very good. And also to a very brilliant young moderator, Dr. Shubha, for being with us. So next, again, Thursday, we have the next series, and the main speakers are Dr. Santosh Honowar and Dr. Radhika Tandon from RPC. And Dr. Usha is the chairperson of that session, and Dr. Parul and Dr. Shubha will be moderating. And I request all of you to join, and especially Dr. Sushmita, please do join and also give your inputs. I'll
Sorry,
share
what is the topics? What are they talking on? So interesting.
if you wait, I'll tell you.
Sorry, I shouldn't be.
Yeah, I'll give you because I'll share the link to you.
Yeah, I would love to join.
Just hold on. I'll wait.
No, it's okay. Just message it.
That is on 8. So Dr. Santosh should be speaking how to write and publish a scientific paper, structuring a research paper, avoiding common pitfalls, and choosing the right journal for publication. And Professor Radhika Tandon will be speaking on the grant writing and securing research funding, the basics of writing successful research proposal, fund findings, funding opportunities, and grant submission strategies.
Wonderful.
That will be very
useful.
Yeah. Dr. Nilesh are the two young panelists, and it will be very nice for Ayushi and also Dr. Anuji to join us. So we'll share the faculty link in the group, and I request all of you to be there.
Sure.
This, I thank everyone. And
thank you. Thank you, everyone.
Coming.
Bye. Bye. Good night.
Good night. Thank you so very much, ma'am.
Dr. Parul, please show your face.
It's disappeared.
अच्छा वाला फोटो ले लीजिए. I had also taken one.
Thank
Okay.
you.
Thank you.
Thank
Bye.
you.
So
Bye-bye.
much.
Bye.
Good night.
Good night.